Now let's move into the final session. We're going to talk, we've moved on, we've talked about diagnosis this morning, we've talked about treatment, the various forms of treatment for local disease. And I'd like to introduce Dr. Duncan Gilbert, who comes from Brighton, who's got that very tricky title of what happens when it all goes wrong. Failed primary treatment, the rising PSA, for me, forms one of the major parts of our work. Any of you who haven't seen that document outside, Recurrent Prostate Cancer by the Prostate Cancer Charity, pick it up. And then we'll compare how that goes with what Duncan tells us. No pressure there then. Duncan comes from Brighton. He's another clinical oncologist, so please.
Thank you. Well, thank you very much to the charity for asking me to speak. And absolutely, as alluded to, when first agreeing to do the talk, I was kind of honoured and accepted. And then as I've thought more and more about it and come to actually put my thoughts together in a coherent fashion, realised that essentially this talk is more about questions than answers, as I'm sure all of you are aware from your day-to-day practice. So in terms of local recurrence, what to do next? So it's recurrence after what? And as has been alluded to and discussed this morning, it's predominantly radical prostatectomy and radical radiotherapy as the predominant curative treatment modalities. But as you'll be all too aware, about a third of patients will experience biochemical failure, depending on a range of risk factors. And so what options are there to discuss? Well, the salvage local therapy, whether that's post-prostatectomy, in which case radiotherapy remains the mainstay and we'll talk in most detail about, or conversely, following radiotherapy, salvage treatments focused either as a radical prostatectomy or focused organ destroying treatments, high-flow or cryotherapy. Against that, there's always the background of androgen deprivation alone, whether continuously or intermittently. But I think from an oncologist's perspective, and it's very easy for us to sit in MDTs and just harp on about, well, there's no randomised data and what's the evidence, but particularly in this setting, there's a real paucity of randomised phase 3 studies to guide us. I think the other key point, which is vital to this, is that local recurrence really, if one had a crystal ball and one knew it was truly local, that's okay, but actually it represents a spectrum of disease. What also is implicit throughout all of this is that it also represents a spectrum of patients. That because it's recurrent, the patient has already gone some way down their treatment pathway and has already made decisions predicated either upon what their beliefs and their tendencies, or often their comorbidities, their overall fitness, whether that's concurrent illnesses, whether it's age, whether it's social factors. But I think just from a statistical point of view, this is just very salient, that amongst a group of patients post-prostatectomy, biochemical relapse, that were managed expectantly or with androgen suppression alone, you've got the spectrum in the patients with long PSA doubling times, low Gleason scores at operation, and times treatment failures are greater than 3 years after their initial surgery. Their risk of prostate cancer death 15 years on is only 6%. Conversely, you've got your patients who relapsed biochemically within 3 years, had high Gleason score tumours with a PSA doubling time of 3 months. Their mean survival, that's survival with androgen treatments and palliative chemotherapy and whatever else, is only 3 years. So there's the spread of patients, there's the spread of disease. How can we define recurrence? It's about 6 years old now, but the ASCO guidelines define biochemical recurrence as greater than 0.4 nanograms. But actually, I think we know, and certainly in the post-prostatectomy patients, that lower evidence of PSA with successive rises predicts biochemical failure. And so the European consensus at the moment, and again, other views are valid, but would be that from an unrecordable level, a PSA of 0.2 nanograms with one subsequent rise is enough to herald PSA recurrence. And those patients do show subsequent PSA progression of, in one study, 100% subsequently. The primary question, I think this is what it all comes down to, is whether that rising PSA represents purely local or distant disease recurrence. And so imaging is, I think, the first of the key questions. And how do we image these patients? I think my routine practice, probably routine practice, would be certainly to get a bone scan. It's routine, it's easily available, but actually, if one thinks conceptually about that, at such low levels of PSAs, these patients will often have had a negative bone scan or will have been very low risk before they had the radical prostatectomy. And looking at various series, the bone scan is unlikely to be positive unless the PSA doubling time is less than 6 months, when 23% of patients had occult metastases shown by bone scan versus only 6% if not. And another study found that the lowest PSA, so it's patients who were tracked, the lowest PSA with a positive bone scan in the absence of hormone ablation was 46. And we've just said that we're looking at people with PSAs of 0.02 and rising. CT scans, well, they've got low sensitivity and specificity at these low levels of PSA. So I think an MR certainly would now be considered standard. MRIs, as you'll be aware, over the last 5 to 10 years have gained evidence and popularity in staging early prostate cancer prior to the initial radical treatment. And recurrences, they take up gadolinium, so they can be seen. They're hypersensitive T2, and again, these all come from recent series that identified a visible recurrence with PSA levels. It's always a range, but a median of 0.8. Still some way above what we've just talked about. I think the other advantage, though, of MRs and pelvic MRs is that there's improved visualisation of pelvic adenopathy at much higher resolution that can be seen on a CT scan. Imaging, therefore, is going to be critical, and if one, in oncology, one always wants a crystal ball, but if one had a crystal ball, what you're trying to define is can you more accurately predict who's truly local? People have investigated PET, but the problem is that standard 18 FDG PET, the tracers are excreted from the kidneys and collected in the bladder, so it's obscure any view of local recurrence. They can show metastatic disease in much the same way that bone scans do, but the same problems exist as I've just stated about bone scans. Looking at other traces that don't collect in the urine are currently the subject of research, and series have been published. Basically, radio traces of carbon in choline or acetate. They have a short half-life, however, making the actual study more tricky, and they may also have higher false positive rates. I think, of anything, Prostate is probably the most exciting, but remains a research tool. And essentially, this is radio-labelled antibodies to PSMA. So it's a targeted imaging modality. You need the same gamma camera setup as PET scans. But what you're actually looking for is not just activity, it's looking for specific PSMA secreting cells. And I think this probably shows the most promise in terms of detecting hitherto occult metastatic disease, so to screen patients who aren't eligible for salvage local treatment. One ends up with images that are sort of apparent to, or similar to anyone who's looked at PET scans. And in this example from the company that make and develop Prostate, one can see, I'll get the mark on here, but you can see on the top scan, it's not going to show very well. Anyway, with the uptake, you can show which lymph nodes, or you can detect lymph nodes that I think on a CT scan, radiologists may have had some difficulty definitely calling as metastatic prostate cancer. Again, however, it's hampered at the moment by multiple small series published with varying sensitivities and specificities. There's a recent review on imaging for local recurrence in our oncology journal, Clinical Oncology, by Mark Beresford, who's a friend and a colleague down in Bristol. And again, it's a kind of both increasing order of complexity and hope, but a decreasing order of evidence. Down at the bottom, sensitivity specificities begin to get up into the 80s, but it's small numbers. But I think future research, as I'll allude to later, should focus on functional imaging, whether that's PET or prostate. So if we take the post-prostatectomy group first, salvage radiotherapy. So I think it would be fair to say that salvage radiotherapy is the only treatment with the potential to cure these patients. There remains no robust randomised data to support its use, but there's a wealth of retrospective case-controlled studies that would support its efficacy in terms of early PSA response. And early PSA responses in terms of getting the PSA back down to unrecordable levels are very good. In some series they're kind of 80–90%. The longer term follow-up, however, suggests that perhaps a third of men will remain biochemically controlled at 8 to 10 years. And the usual prognostic indices fall out. PSA level at the time of salvage radiotherapy, the PSA level preoperatively, PSA doubling time post prostatectomy, and the Gleason score of the surgical specimen. I think, as I alluded to at the beginning, the point when there's no randomised data to support this is that it comes down to risks and benefits, and that's why your role is more important than mine in discussing this with patients. In terms of the actual radiotherapy, most studies used less than 70 gray. 66 gray remains the probably standard dose in the UK. But as will have been discussed earlier, radiotherapy is changing and the way we do radiotherapy is changing. The capacity to more directly target radiotherapy allows for dose intensity, so increasing dose. And there is some data from earlier studies in intact prostate cancer that prostate cancer is, it does have a dose response. So is 66 gray enough? The next question, leading on from the CHIP study that I think will have been discussed also, is, well, what about fractionation? If we're trying to kill prostate cancer cells using external beam radiotherapy, then if the fractionation of that treatment is important, then that's going to need looking at in the salvage setting as well. I think it'd be fair to say that acute toxicities are relatively infrequent, but what's of much more concern to patients are the concerns around worsening the pre-existing urinary symptoms, incontinence, stricture, impotence, and following the first surgery. Those figures, however, seem, again, it's hampered by retrospective reviews, but mainly dictated by the prior symptoms of the patient, as opposed to radiotherapy de novo introducing new symptoms to patients. Again, from Mark's paper, how we do the radiotherapy at present is actually relatively crude. On the top, there's a CT scan that because we use CT for radiotherapy planning, that shows the clip still in situ following radical prostatectomy. And the lower one is the radiotherapy volumes that we treat. And whilst the CTV and the PTV, the planning target volume, which is the area we as oncologists ask our planners and physicists to treat, looks quite a nice kind of concave shape of the prostate bed, by the time you've shone even conformally shaped beams, you end up with treating much of the pelvis. As will have also been discussed earlier, there's increasing data, and it's now standard treatment, to combine adjuvant hormone therapy with radical radiotherapy. And from a physiological and molecular biological point of view, then that would seem sensible if we're going to try and eradicate prostate cancer the second time around. Again, the 3 retrospective series report the benefit of addition to short-term androgen deprivation to salvage radiotherapy, but again, there's no data. But the radical study, which has already been mentioned, and Matt may mention again, which we haven't, this isn't meant to be a huge advert for radicals, but if it is, that's a good thing, includes a hormone randomisation in that setting. I'll come back to radicals a little bit later on. Now, what about recurrence post-radiotherapy? What are the options there? So, again, the same caveats apply. If you can convince yourself, or if you can be reasonably certain that it's local disease only, then you can look again at local ablative therapy. And that really boils down to salvage prostatectomy, or HIFU or cryotherapy, leaving the prostate in situ but destroying it with thermal ablation, whether that's HIFU or cryo, versus the fallback position of hormone manipulation. Radical prostatectomy post-radiotherapy is something that, at least locally in the MDTs that I go to, is rarely discussed and is taken very seriously by the urologists, but I welcome other people's opinion. I think really it boils down to the increased complication rate. As an oncologist, I kind of hesitate to kind of flag up surgical complications. But from the most up-to-date and from reputable studies, there clearly are high rates of fistula abscesses in retention in patients with prostatectomy post-radiotherapy. Continence rates perhaps 30%. What there isn't is data on long-term outcomes. And I think the problem that I see with this, and the problem I see with my patients, is that in an MDT setting, where patients have had all options discussed with them, patients who've gone for radiotherapy in the first instance have usually gone for it for a good reason. And they are usually older. They do usually have comorbidities that make surgery a less attractive option. And for all those reasons, surgery second time round, I think is much harder, both for the patient and for the MDT team. Again, I welcome other points of view. So in terms of leaving the prostate in situ but eradicating it from without, HIFU and cryotherapy, both ways of ablating the residual tissue. They're funded, or at least they're funded locally with us as Salvage within the NHS. And again, there are retrospective series that show good or reasonable rates of progression-free survival. Both these two most recent studies actually show exactly the same, 44% progression-free, one at 18 months with HIFU, one at 3.4 years with cryotherapy. HIFU, as probably you're more aware as urological nurse specialist as opposed to an oncologist than I, is using high-intensity focused ultrasound to get thermal ablation, so focused, very high temperatures, destroy the prostate from within. Applicable for patients who've had external beam radiotherapy, neither of these really recommended for patients who've had brachytherapy because of stricture rates, they're very high radiotherapy dose and fibrosis after brachytherapy. Both performed in similar fashions, cryotherapy using guided probes cooled to -40, creating ice balls within the prostate and ablating the prostate that way. Similar benefits, significant risks of impotence if nerve sparing is not done, and that all comes down again to, in the salvage setting, where's the relapse, and can you be as specific as you were in the upfront setting? In a retrospective US series of nearly 800 men, with a reasonable median follow-up of 3.5 years, there was a 44% relapse-free survival. Again, randomised studies of these. And I think as oncologists, we don't necessarily discuss salvage post-radiotherapy, perhaps as often as we could do. So what about the future? I think we need prospective studies of the imaging modalities to better identify truly localised disease. I wonder as well whether, instead of just looking at imaging, whether novel biomarkers of occult metastatic disease might be useful. If we go to the literature coming out of kind of systemic treatment in prostate cancer, looking at responses to chemotherapy, to the more novel agents, circulating tumour cells, plasma DNA, can all be used to detect occult disease. And perhaps in a salvage setting, there may be molecular tools we can use to give a better idea whether the disease is truly localised. Salvage radiotherapy studies are going to need in the future, if we've shown that salvage radiotherapy is truly of benefit, then they'll need to look at dose and volume using modern radiotherapy techniques. You'll have already had talks about image-guided radiotherapy to make sure the patient's where we think they are and we're treating what we think, and then IMRT so that we can treat conformally to a higher conformal shape, and then start looking at dose and potentially fractionation. Radicals, which again I'll allude to in a minute, but is there a role for additional systemic treatment with these patients that relapse? Because for some of those higher risk ones, if we get it wrong and they truly do have metastatic disease, then their disease is going to be progressing. Now, that can be adjuvant hormones, but along the lines of trials you'll hear about tomorrow, Stampede and beyond, the treatment of metastatic prostate cancer with systemic drugs, whether that's docetaxel or the newer highly active hormone agents like abiraterone or MDV. Now, should we be hammering these patients harder locally? We do in breast cancer, they get adjuvant chemotherapy. Should these patients be getting adjuvant treatment at the time when they've shown themselves to be high risk because they've already relapsed? And finally, adjuvant versus salvage radiotherapy is a pressing issue, and it goes some way to answer some of those problems. So radicals, post-radiotherapy patients with high risk, so T3-4, Gleason 7 to 10, a higher pre-op PSA or positive margins, are randomised either to adjuvant or to delayed, that's salvage radiotherapy, and if they are to receive that radiotherapy, they're then randomised to non-6 months or 2 years of androgen deprivation. So in this group will be patients who get salvage radiotherapy not as part of the study, but get salvage radiotherapy because they're relapsing, and they will have a hormone randomisation. So that'll go some way, should answer whether or not 6 months or 2 years of hormones improves outcomes from salvage radiotherapy. It will also give us another robust prospective series of outcomes from patients with having salvage radiotherapy. Now, whether, as the study's up and running, other studies, imaging studies, biomarker studies can be bolted onto that study is a moot point. So, in conclusion, I think the heterogeneity of the disease and the lack of randomised data make patient-centred decision the most vital, and it really does come down to patient comorbidities, to patient-related factors, and, as best we can, tumour-related factors. All active treatments have significant side effects, and we need national and international coordination and support for ongoing and future clinical trials looking at all these different modalities of care. Question?
Thank you very much. Duncan, this is a difficult area, isn't it? And I think you've addressed it very well there. I must say, from a personal point of view, the way I try to do it is to set expectations for patients early on, because before you actually embark on primary treatment, you have an idea whether it's going to work or not. And for the patient who's got high-risk disease, to say to them, do you know, we're going to treat you with surgery, but it may be that that may be part of a multi-modality treatment program. So when it comes to the rising PSA or the adverse histology, you're not batting on a new wicket, you're just carrying on with what you started off doing. And I find that a very useful approach. Can I come back to you and ask you what you really do in Brighton? Because I heard you list these fantastic number of tests that can be done.
Yeah.
And I just wonder how many you do.
Yeah. I mean, I think despite the limitations, we would still do a bone scan.
So hang on, you've got the guy who's had a radical prostatectomy, may have adverse histology.
Yeah.
From what I'm hearing, you don't rush to put him into radicals.
At the moment,
He's gone.
He'll be back and he'll be talking about radicals. It's about to be opened, so we will be. And I think it comes back to absolutely what you're saying, that the advantage for us as oncologists as radicals is that it gives that option for a trial-based approach, so that patients can be approached beforehand with radicals information, with the idea that there will be some questions after if you're a high-risk surgical candidate. And it does focus the follow-up, and it focuses our MDT on discussing those patients and paying more attention to the histology and paying more attention to what happens after the prostatectomy to pick the patients for radicals. Whereas in the past, I guess it was left to individual urologists in their own practice a little bit more.
So you'll be a fan of radicals and you will encourage your surgical colleagues to put their patients into it.
Yeah.
Whether they feel that a number of those patients will be over-treated or not will be a matter of discussion, won't it?
Absolutely, and like any good and robust MDT, there will be
robustness.
There will be robustness, and there are the patients who clearly need adjuvant radiotherapy, and the urologists will be pushing for that, and that's fine. And there'll be patients who it possibly is over treatment, and perhaps we'll be drawing back a bit from them. And it's always a discussion.
So back to real world.
Yeah.
Failing primary treatment, rising PSA.
Yeah.
What tests do you do? What imaging? You know, lots of sophisticated imaging.
Yeah.
What do you do?
So we would still do a bone scan. When we see them as oncologists, we do a bone scan.
Regardless of the level of the PSA?
I think we would be conservative before we embarked on salvage radiotherapy, despite the figures that I've just shown.
Right.
It's a question, but I think we would. And I think we'd push locally for an MR.
You mentioned endorectal MR there. You don't do that, do you?
We don't in Eastbourne, we do in Brighton.
Oh, right, okay. So they get that.
Yeah.
Prostate?
No.
You don't do that?
We don't do prostate and we don't do more complex PET.
Okay.
No.
So with that imaging, you'll be making a decision about radiotherapy, and I think once they've gone through those tests, it's likely they'd get it.
Yeah.
PSA comes down and then does what it always does, which is comes up again.
Mm-hmm.
What do you do then? Sorry, I'm pushing this because
I
think it's the difficult area you couldn't focus on, so I'll push it.
Yes.
Because you'll all see these patients in your clinic.
Yeah.
People with failed primary treatment, rising PSAs, what do you do with them and when?
Yeah.
So what's next?
I think it is incredibly difficult, and second time round, you've got to use clearly higher cut-offs of PSA. You've got to be more you've got to be more frank with the patients that they've selected themselves out that this is more aggressive disease. There aren't any more salvage options, and really what you're looking at is when do you start hormones?
And when do you?
I think you can come back to PSA doubling time. You can come back to patient fitness. I think also though that the data recently on long-term effects of hormones puts a bit of a dampener on this, not just in terms of acute side effects, but in terms of bone health, which is not an easy subject and gets more difficult each day with problems with bisphosphonates, problems with calcium, cardiac side effects, DVTs. The risks are all there.
Risks and benefits, isn't it?
It is always risk and benefit, and it does come down to how hard the patient pushes. I mean, my most recent patient, his PSA had only got to 4, but was pushing for hormones, and that was absolutely reasonable. Having been through the mill of 2 radical treatment options, then difficult to argue against it.
You mentioned the Steve Friedland paper there, and I think that gives us the best information. It's Gleason grade, it's PSA doubling time, and it's time to recurrence, isn't it?
Yeah.
And you can predict for them when they're going to go wrong.
Yeah.
So you can almost draw the graph out and say, you'll be going wrong about here. Until then, chill.
Yeah.
But as you say, they'll want to pull the trigger when they want to pull the trigger.
Yeah.
And what I've learned about those patients is they're absolutely right for intermittent treatment.
Yes.
Because you bring down the PSA and their only source of worry has disappeared.
Yeah.
Now, whether you're doing any good by continuing the androgen deprivation therapy, I doubt.
No.
But I feel I'm doing slightly less harm by intermittent treatment rather than carrying on with it continuously.
Absolutely, and because there's a lag after, especially long-acting GnRH analogues, then you can stop the treatment, but there'll be a lag before the testosterone picks up, and then a lag before the PSA picks up. And you can buy the patient significant time off treatment. I'm not aware, well, the Intercontinental study looked at intermittent hormones, and I meant to try and look for the most recent data before now, but I'm not aware that there's any detriment to that course of action.
It's not worse, is all you can say. It will never be better.
Yeah, yeah.
Views from the audience, questions for Duncan. I'm sorry I put him under the spotlight there, but I suppose that's my job. Who wants to ask him questions?
Cathy Samuel, I'm urology CNS at Brighton.
Oh, well, let's hope you're on his side.
I just wondered if somebody actually has castrate-resistant prostate cancer and they then have HIFU, do you see any benefit of continuing hormones after that?
If they have castrate-resistant disease, i.e. they've been progressing on hormones and then go back for HIFU.
Yeah.
I mean, I think there's a pragmatic answer to that, and there's the scientific answer. And I think there's a wider issue of, do you carry on hormones when patients seem to already have failed hormones? From a scientific point of view, I would be unhappy to see someone who's demonstrated aggressive disease, their testosterone levels coming back to normal. I think if you look at why people develop castrate-resistant disease, there's enough data now that the cells are still testosterone sensitive, hence abiraterone, hence MTV. Now, okay, the ones that are growing at castrate levels of testosterone, but to then flood the market and increase the testosterone again just doesn't make sort of scientific sense. Clearly there's no data. There'll be times when patients are having such a rough time that they'll stop the hormones, that's fine, but I would counsel them that, to the best of our understanding, hormone treatment remains a backbone of anything other than truly early disease, and that letting testosterone levels rise in that setting, unless it's part of a managed intermittent treatment in discussion with the patient, I think would be tricky. Coming back to local therapy in the face of rising PSA in a castrate-resistant population, it is an interesting one, and it's not just HIFU, but we do it with radiotherapy sometimes as well, with the patient who's perhaps was declined radiotherapy first, was on a watchful waiting, had reasons, perhaps social reasons why they didn't want radiotherapy, and have been in hormones for many years. As they begin to develop castrate resistance, then sometimes you go back and revisit well, actually, if we can't demonstrate metastatic disease anywhere, should we go back and irradiate them now? And we do it on occasion.
And it produces symptomatic benefit, as Peter told us.
Absolutely, absolutely. So you justify it for local control, but it often produces PSA responses too. And,
sure.
Yeah.
In answer to your question about the hormones, that patient's got limited life expectancy. I think he sees you pulling the plug on one of his medical treatment arms. He kind of gives up a little bit more.
The reason I asked the question is the neurologist disagrees with the oncologist in the situation that I was in, because I was just interested to hear another side of the story.
More robustness there.
Local robustness indeed, yes.
I know the urologist, and I'm sure it is robust, and I think probably the consensus view is you will continue with treatment. Anyone else? Any other comments, Duncan? I'll make a mention of the surgery, the salvage surgery after radiotherapy. It's not good.
No.
Patients haven't chosen surgery in the first place. And do you know the complications for salvage radical prostatectomy are significantly greater than a radical prostatectomy? And only if the patient wants to absolutely throw the book at the last chance of cure, recognising complications that will occur, would I even consider it. And even then, it's a technically difficult operation. So, we've covered some of the issues there, rising PSA, failed treatment. I think one of the questions that was thrown up by Duncan's talk is, when you don't know what to do, we should be doing a study. We're clinicians first and foremost. We're highly educated doctors learning to ask questions about things we don't understand.